Welcome, everyone. I'm Dr. Carmen Pugliafito, and I'm here today with Dr. Michael Stewart, who is Knights Templar Professor of Ophthalmology at the Mayo Clinic in Jacksonville, Florida. Michael, welcome to
Well,
Retina
Carmen,
Senses.
Carmen, thank you very much. Really a pleasure to be talking to you today.
Well, it's a privilege to talk to you because Michael is a two-decade veteran of anti-VEGF therapy. And so presumably he's learned a lot in those 2 decades of treatment. Today we're going to talk about a new generation drug, Aflibercept, 8 milligrams, in the treatment of neovascular AMD. And Michael presented data which suggests that early treatment response to retinal drying in high dose aflibercept patients may be a good predictor of increased dosing interval. Did I get that right?
That's exactly correct.
So tell us about the study design. And this was a long-term study. It was 96 weeks.
Yep.
Tell us the design of the trial and what happened.
Yeah. So this was the phase 3 registration trial for aflibercept 8 milligrams, and it goes by the name of Pulsar. Pulsar, as you know, randomized, prospective, double-blind, multi-center trial across the world, and it looked at trying to figure out if aflibercept 8 milligrams was non-inferior to aflibercept 2 milligrams when 2 milligrams was given in our standard posology. 3 monthly doses for patients with new onset neovascular AMD, followed by Q8. And the goal of the trial overall was to try to establish non-inferiority with respect to visual acuity gains over the course of 52 weeks, and then as a secondary endpoint, 96 weeks, while showing extended durability. Because let's face it, Carmen, as you know, when we started anti-VEGF, it seemed like every time we turned around, we were looking for a drug that gave us better results, better visual acuity, better results, better drying. And once we got past aflibercept 2 milligrams, we realized we're not likely to get that going forward. And everybody subsequent to Regeneron with aflibercept 2 milligrams has looked at superiority, but nobody's been able to achieve it. So as a result, everybody's pivoted to trying to get extended durability. And that's what this study was about, is to try to get extended durability. So similar to the 2 milligram patients, and this was randomization at baseline, patients receiving 8 milligrams were randomized to the Q12 or Q16 cohorts. And of course, each of those was after 3 monthly loading doses. Got their 3 doses, and then they immediately jumped 12 weeks or 16 weeks and were treated at those intervals through the first year unless they met dose regimen modification criteria, which made them eligible for shortening by 4-week adjustments, but they could not be lengthened during the first year. During the second year, they were eligible for extension, again by 4-week increments. And the extensions were done if patients had no central subfield fluid, either intra or subretinal, and they had fewer than 5 letters of visual acuity decline compared to week 12, because week 12 is sort of 4 weeks after your 3 loading doses. You think this is probably about as good as you're going to get. And so that's the comparator. If they met those 2 criteria, they were eligible for extension in the second year up to week 96. And for those patients fortunate enough to do very well and meet those criteria, they could max out at 24-week intervals at the end of 2 years. For purposes of looking at who did really well, we sort of think 5 months or longer is a good number. So Q20 or longer is sort of our really top end that we're looking for in this trial. So the question becomes, is there early data from the trial that may be a predictor for who's going to get those extended intervals in the long term versus who needs more frequent intervals and hence fewer percentage of patients at Q20 weeks or longer at the end of week 96. And so the study was looked at whether or not patients had persistent fluid at 4 weeks, 8 weeks, 12 weeks, um, after the beginning of the trial. And then they broke that down into multiple different combinations of dry, wet through the first 12 weeks. 5 different groupings were analyzed. And when it comes right down to it, it's the presence or absence of fluid at week 4 is pretty much the only significant predictor of whether or not patients can get extended intervals at week 96, or whether or not they're going to be frequent flyers, require more treatments, and hence not being able to be extended to 20 weeks or longer. They can be dry at week 4 and dry at 8, dry at 12, or dry at week 4 with recurrent fluid at 8 or 12. It didn't matter. 4 was the magic number. And then on the other side, the same thing happened. If they were wet at week 4 with intra or subretinal fluid, it didn't matter if they were dry at 8, wet at 8, dry at 12, wet at 12. It was only the 4 that was the predictor as to whether or not they required more treatments, and hence they couldn't be extended as long. And so when you look at the numbers at week 96, those patients who were dry at 4 had a 53 to 54% chance of being Q 20 weeks or longer at the end of week 96. Conversely, those who were wet at week 4 had only a 37% chance of being extended to 20 weeks or longer at week 96. So, we've always asked questions of, can we predict at baseline who's going to be a good responder or not responder? And we look at severity of baseline disease and other biomarkers. This is the first one that really looks at early data, and not just 12-week response, but a 4-week response, and uses that as a pretty strong predictor of who's going to do well. And by well, we mean who's going to be able to be dry and who's going to be able to be extended, because extension and durability is really what the trial was about.
So what were the results, just to reiterate, of those patients who were absolutely dry at 4 weeks? What was the mean treatment interval that they could achieve at the end of 96 weeks?
Yeah, so the mean interval was just a fraction over 20 weeks. Or at least that was let's say that was the median, because 53 to 54% of them were 20 weeks or longer. So half of the patients, just over half, were 20 weeks or longer at the end of week 96 if they were dry. We haven't gone through a mean because there is a variability from a few patients requiring Q8, some at 12, some at 16. But the median is just over 20 weeks.
That's wonderful. What percent of these patients needed rescue? And that, do we know that number?
Yeah, well, we do, in the sense that rescue, and I would define rescue as meeting the dose regimen modification criteria.
Right.
What percentage of patients couldn't maintain that 12 or 16-week interval at least through the first year? And the answer is about 22 to 23%. 22 to 23% of those couldn't match the 16-week interval that they had been randomized to. The flip side of that, of course, is 77 and 78% of patients were actually maintained on Q16-week intervals with stability of disease relative to where they were at week 12.
Some of those patients that needed more immediate treatment, how many of them ended up out with that 20-week duration, do you think?
Fewer of them, and I don't have a date. I don't have an answer on that. We've got all of the lanes that we've looked at, the swim lanes, if you will. By virtue of having their intervals shortened by 4 weeks, you eventually run out of time at the end of week 96. You can't get them to 20 weeks or longer because you can't get there fast enough. Because remember, during the first year, that patients could only have their intervals shortened. They could not be extended. So they might have been shortened after the first interval to 12 weeks instead of 16, but they weren't eligible for extension until they hit week 96, or week 48 rather. Mm-hmm. So they were a little bit disadvantaged and couldn't get out there fast enough. Once they got up to 3 years, then about half of them were maintained at 20 weeks or longer, and many of those patients could catch up because they had sufficient time. So I don't have a good number for you, but there during year 2, there were a significant number of patients who had their intervals shortened. Remember, that was only about 22% in the first year. But there was a significant percentage of those who actually had extension of interval in the second year because their disease was adequately controlled, and now they were eligible for extension.
So in the real world, if you have a patient who's taken high dose aflibercept and is totally dry at 4 weeks, does that mean that you can be more aggressive in a thoughtful way in extending those eyes?
I certainly believe so. We don't have the good data to show that yet, and the phase 3 trial did not allow that. But
Right.
when you look at the fact that 4 weeks was your determining factor and 8 and 12 didn't make much difference, in my opinion, yes. So, how many loading doses do you need? You only need one if it works well. And 56% of those patients who received their first aflibercept 8 milligram dose at baseline, 56% of those were completely dry at week 4. So that's more than half of your patients. You could probably begin to extend as soon as you give your second injection.
So are you saying that 3 loading doses may not be necessary in some of these eyes?
That's my belief, yes. I think that what you do is you look for a good anatomic response. And if you're dry, then you can use the OCT as a way of determining how quickly you actually begin to extend. I've never believed that 3 loading doses is necessary, but I believe that you shouldn't start to extend until you see resolution of fluid. But if you see that at the first injection, and this data supports that belief that you can start to extend immediately, as
So
long
you'll
as you're
see them.
watching the OCT.
So you'll see them at 4 weeks. They're looking great. You'll see them at 8 weeks. Will you see them again at 12 weeks?
So what I'll do is I'll see them at 4, and what I'll do is I'll start this as I'll say, let me give you another injection, and now I'll see you 6 weeks later. Let me give you
Okay.
another
All right.
injection, and I'll see you 8 weeks beyond that. I'm still a little more conservative than those 12 and 16-week jumps that we saw within the trial, and even a little more conservative than the 4-week dose regimen modification criteria for extension or contraction. But I think beginning to extend earlier makes sense as long as your OCT supports that. Although I'll go at 2-week intervals just because I'm old school and I don't jump to 4 just yet.
Well, that makes sense. Really, it does make sense. And those 2-week intervals, after a while, they add up, don't
Yes, they
they?
do. They
They
do.
sure do.
Yeah.
Now,
The other part of that, though, is what I found myself doing more recently is as I'm getting longer intervals, I'm getting bolder. I hit 10 weeks, and now I say, okay, let me see you back in 3 weeks. I hit 16 weeks, let me see you back in 4 weeks. Because I think that the difference between 16 and 20 is much less than the difference between 4 and 8.
yes.
So I get bolder as we go further out.
So do you think that we have other durability enhanced agents like Vabysmo,
Yeah.
faricimab? Do you think that if we looked at the faricimab data, we'd see the same biomarker?
So they have looked at that, and there have been presentations early this year. I couldn't find the exact details of the criteria they used to look at who were the early responders, but their data is very similar, where patients evaluated 4, 8, and 12 weeks, then when they had favorable drying in Tenaya and Lucerne, they were the ones who were most likely to be extended up to 16 weeks. So, and their odds ratios were about 1.6 to 1.7. And so if you compare that odds ratio to the 53 to 37, it's not much different. And so the same concept would appear to apply to Vabysmo, and for probably all the same reasons. A high efficacy agent with good durability signals, you should expect similar results. And I think it's reasonable to apply similar criteria to using Vabysmo versus 8 milligrams.
That's fantastic. So this really offers hope for fewer injections to a subgroup of patients. What percent of eyes in the study were completely dry at 4 weeks again?
56%.
56. Wow.
56 of the 8 mg patients, yes.
Wow. What do you think that number would have been with the 2 mg patients at 4 weeks? We didn't really look at that, did we?
We did. Well, we looked at them.
At 8 weeks.
Obviously they weren't subject
Right.
to this analysis, but they were looked at separately, and it was about 46. So it was
Yeah.
about a 10% differential.
So do you think the phased dosing would also be useful in eyes treated with the 2 mg dose regimen?
I do. You know, you got to be a little bit more cautious.
Yes.
And the reason for that is you probably don't have the peak efficacy for drying that you do with 8 mg because of drug concentration. And of course, you don't have the same durability. So the concept would be the same, but the pace would be a
Yes.
little slower.
Yeah. Yeah. The monitoring would need to be closer.
Correct.
Right. Well, this is fantastic. Now, I'd like to delve into another topic. We've had 20 years of Avastin. What have we learned?
You know, it's very interesting. We've learned Avastin's a good drug, and it's not the perfect drug, and it's not our best drug. But let's face it, with the cost as we know what the drug does, it's still a very good drug. Now, as a drug that was never developed for intravitreal use, for the majority of patients with neovascular AMD, they'll get similar peak efficacy effects as we will with any of the other drugs we use. What I think Avastin lacks is the durability. And I think it comes up just a little bit short in things like polypoidal choroidopathy, expanding pigment epithelial detachments, and the 20/50 or worse diabetic macular edema. So if you look at those as being a little bit inferior, but those are only subsets. And so when you look at the majority of patients, especially with neovascular AMD, it is certainly a good first-line choice. I don't think at this point in time, we can argue against that.
Mm-hmm. What do you think about Avastin dosing? How do you manage those patients? Do you give them 3 loading doses, or you don't believe in loading doses?
I don't believe in loading doses, and I look back at CAT, and what was the loading dose in CAT for the PRN arm? 1.
1. Correct.
And I like to compare that to Ivan, because in Ivan they had sort of similar protocols, except in Ivan, every time they had recurrent disease, they gave 3 loading doses monthly. But what's interesting was at the end of 1 year, the differential in visual acuities between the PRN arms in CAT and the PRN arms in Ivan, between PRN versus monthly, were pretty much the same, and the number of injections on average were the same. So I'm not convinced the 3 loading doses is necessary either initially or subsequently. I think the key is watch the OCT and let the OCT define how many loading doses you need at any given moment.
What about comparing Aflibercept 8 mg with faricimab? Do you think the durability results are very similar?
So it's really hard to tell. And we've looked at this with 2 mg versus Aflibercept, 2 mg versus 8 mg, and 2 mg versus Beovu. And I think that the durability is in favor of the second generation agents. What I don't know is what the numbers are, because we've not allowed 2 mg to be extended out, and we don't know the answer. I think on the top end, it's anywhere from 6 to 8 weeks. On the bottom end, it might be 2 to 3 weeks in terms of an advantage to the second generation agents. But where it fits within that, until somebody does a study that treats both the 2 mg and the second generation agent patients exactly the same with respect to criteria, we'll never know that. And the bottom line is some academic institutions may well do that, The drug companies aren't going to do it. DRCR net's not going to do it. So we're not going to have that really well-controlled phase 3 trial to know the answer. But I think it's somewhere in that range of better, but probably not as much better as we might like it to be.
Well, this has been a tremendous discussion and very practical. Uh, and this is a valuable biomarker. And it's a simple biomarker, isn't
Yes.
it?
Yes, it is. It is one number.
It's one number.
Yep.
Look at that intraretinal and subretinal fluid.
Yep.
If it's not there,
It's binary.
you can tell the patient you might do very well.
Yep.
Thank you very much for participating in retina synthesis, Michael.
Carmen, my pleasure. Thank you.